Okay. Bridget, it's 4 o'clock now, and I see we're about 36 participants. Can I start?
Yes, Annika, that's great. Go ahead.
Okay. Well, good afternoon, everyone, and welcome to today's deep dive hematology. The topic we're presenting today is the genetic landscape of acute myeloid leukemia. I'm Annika van Melle, and I have the honor of being the chair for the session today. Before I introduce our speaker, I'm just going to run through some housekeeping notes. Is it going?
Yes.
Oh, perfect. Thank you. So just please note that these sessions are recorded and these recordings will be available on the Blood SA website, should you want to go revisit it at a later stage. And please, we encourage you to put comments, questions, share experiences in the chat box so that we can have a nice interactive session afterwards. If you want anyone that you know to be added to the mailing list, please email Melanie Davids. As Prof. Vernon Lowe has previously said, that although this is hematology centered, it's not only intended for hematologists, and it's actually nice to have people from different disciplines taking part in the discussions at the end. This program is CPD accredited, so for all South African citizens, it will automatically be submitted to HPCSA, provided that you've attended for at least an hour. For those from outside of South Africa, now advanced quickly. You are welcome to again email Melanie Davids, and she will send you a CPD certificate. Sorry, now I skipped through something. Just also, please, we value your feedback. If you could take the time just to fill in the anonymous survey at the end to give us some feedback and help us improve this program. Okay, then just a reminder of the 16th Annual Hematology Oncology Symposium that's just around the corner. It's from the 13th to the 15th of September in Cape Town. Please register if you haven't done so already. It's always a very exciting event. And I think this year more than ever, it's going to focus both on the clinical and the laboratory aspects of hematology, and also both benign and malignant conditions. Oh, and then, of course, notes for us, it's easy. You just, on a Monday afternoon, log in and we have access to this wonderful platform, but there's a lot of time and effort that goes in behind the scenes. And this is all thanks to our management team, Prof. Stelferberg and her colleagues, Gerdien, Bridget, Nicole, and Melanie. Thank you very much. We appreciate you. And we really just want to acknowledge you here as well. And then, yes, it's my pleasure to introduce you to our speaker for the day. It's Dr. Kate Hodkinson. Kate is a hematopathologist at Wits NHLS, where she heads up the somatic cell and genetic unit there, and she plays a critical role in advancing the understanding of genetics and diagnostics in hematological neoplasms. And with this being such a rapidly evolving field, molecular diagnostics and genetics really has become the center, probably one of the most important aspects of both clinical and diagnostic hematology. But I know myself, but many others of us find this very intimidating still. So we're really glad that someone like Kate has taken up the challenge for us, or taken on that challenge. But just from a personal point of view, Kate is a very humble person and she's very approachable. I've often just sent her a WhatsApp asking some random patient's results, and she's always very helpful and very friendly. Kate, thank you for sharing your knowledge with us, and over to you. We look forward to your talk.
Thank you. Thank you very much, Annika, for such a lovely introduction, and to the Deep Dive team for inviting me to speak on this platform today. I feel very honored. So just to give you an outline of the talk I'll be giving this afternoon, I'm going to be breaking it up into two major parts. The first half, I'm going to be walking you through the actual molecular components of AML, just to give you a better understanding of the genes that are involved and the pathways that are involved. And then for the second half of the talk, I'm going to be showing you some real-world NGS data from our public sector, and showing you how it relates to that we have seen reported in our first world countries. So the reason for this extremely dramatic painting on the left-hand side of my image here is to really just bring home the message of how complex AML is, And especially in terms of its heterogeneity, we know clinically what we see down the microscope, the expression profile on flow cytometry and the genetics. It is an extremely heterogeneous condition. And so let's begin having a look through the genetics of this condition. So the pathways I'm going to be unwrapping are going to start on the surface, and we're going to look at activated signaling pathways like FLT, KITs, N, and KRASs. We'll then move into the cell, and we're going to look at some of the factor fusions onto the tumor suppressor genes, give you a bit of a better understanding of what chromatin is and what chromatin modification means, show you what the spliceosome is and how it works, and then end off with nucleophosmin 1. So starting with our FLT3, this is our FMS-related tyrosine kinase, and this is a transmembrane receptor that is present on hematopoietic progenitor cells. And it functions in transmitting signals through that are controlling cellular proliferation, the differentiation of cells, and cell survival. And it does the signaling through 3 main pathways, are RAS-RAF, JAK-STAT, and PI3K ACT pathways. In AML, we see variants in 2 dominant regions. And these are gain-of-function mutations which cause an expansion in the tumor pool. It causes a differentiation block at the level of these blasts, and we get immortalization of these tumor cells. Now, the first of these variants occur within exon 14 and 15 of our FLT3 gene, and it's in this juxtamembrane region. And here we see our classic internal tandem duplications. So here we get these repeats of 3, which range in length from around 3 to just under 400. And just to give you a little bit of a background on our NGS sequencing technology, just be aware that on some of our NGS platforms, like the Myeloid platform that we offer at WITS, very long length ITDs will not be detected due to the read length of our specific panel, which is around 250 to 300 base pairs. The second most common region that is involved is in exon 20, and this is our tyrosine kinase domain. And here we see gain-of-function missense mutations with our D835, the characteristic one we see in AML. So how does this translate prognostically in AML? So with the new ELN, we see that our allelic ratios have largely been abandoned or have been abandoned. And FLT3 ITDs fall within an intermediate risk category, which is irrespective of the mutation status of NPN1. This is obviously in the absence of adverse genetic risk factors. In terms of therapeutic impact, we know that FLT3 mutated AMLs will qualify for FLT3 inhibitors like midostaurin, based on the specific variants that are present in terms of TKD and any of our ITDs. And those patients will qualify for the use of midostaurin in conjunction with intensive induction therapy upfront. FLT3 has a specific role in APL, and we see FLT3 ITDs in around 1/3 of cases. And these are typically young patients who have a very proliferative picture, so high blast percentages, higher white cell counts. And we know that FLT ITDs and TKDs are associated with poorer outcomes. But what's important to know is that is overcome by treatment with arsenic trioxide. I want you just to hold this specific point in your mind, to keep it with you until we come through to the public sector data, where we will see the impact of these FLT3 ITDs and TKDs. I just wanted to give you a single slide on our N and KRAS proteins. So these are present in around 6 to 10% of acute myeloid leukemias, and they transmit growth signals from our surface receptors through very similar pathways. And again, they control proliferation, survival, and differentiation of cells. Our N and KRASs are also gain-of-function mutations, with our G12 and our G13 are most common. But what's important to note in AML is that our N and K RASs are actually subclonal events. So they have a role in the pathogenesis and progression of AML, but they do not feature prognostically within our ELN risk stratification. The only exception in terms of literature is our NRAS, where we have seen it to confer a favorable prognosis in the setting of co-mutations with DNMT3 and nucleophosmin-1. We've seen with our latest WHO that there's a whole list of our defining genetic abnormalities with numerous fusions that are in place there. And I just want to remind the audience of our very basic core binding factor leukemias and how they play a role. So we have our RUNX1, which is our core binding factor alpha subunit. And this is our DNA binding domain, and it's the major regulator of transcription. And to that RUNX1, we will have a core binding beta subunit. And together, those two regulate hemopoietic differentiation. Now, in the setting of a fusion with a partner gene like RUNX1T1, we suddenly have a very strong co-repressor, which is fused to RUNX1, and that results in a differentiation block. But what we have seen over the decades is that these fusions are not sufficient enough to actually cause the leukemic development and progression. And there is a need for cooperating pathogenic events, and these are typically involving epigenetic cohesin pathways and RAS pathways in order to actually drive the process towards overt leukemia. If we look at our KMT2A rearranged AML, we classically see our break in the KMT2A around exons 5 to 11. So we remain with the promoter region of KMT2A fused with a partner gene where over 90 have been reported. Now, KMT2A functions in normal hemopoiesis, and when rearranged, the expression profile of the KMT2A rearranged cells is that of early progenitor cells. And they will have an increased expression of proteins like HOXA and EV61. And that leads again to this expansion of this progenitor pool and differentiation arrest. In terms of cooperating mutations in KMT2A, we often see subclonal variants present in our RAS and our FLT3 pathways, but these are often at very low variant allele frequencies of less than 10%. So what's remained unchanged is the location of these core binding factor leukemias in our ELN. They still remain within a favorable risk category. But what I wanted to bring your attention to were these symbols that were located adjacent to both the 821s and inversion 16. And the footnote in these regions says, concurrent KIT and FLT3 gene mutations do not alter risk stratification. And again, I want you to remember these for the second half of the talk when we apply it to our real world data. In terms of our KMT2 rearranged AMLs, the prognosis is directly related to the partner genes that are involved. So we all know TP53 as the guardian of the genome, and we see TP53 mutated in around 10% of our de novo AMLs. And this proportion increases quite dramatically in cases like therapy-related AML. There's an extremely strong association between TP53 and complex karyotype, which we see in around 2/3 of cases. And as that cytogenetic complexity increases and or the variant allele frequency of our TP53 variants increases, the prognosis becomes more and more abysmal. So in the event of cellular stress, our TP53 protein relocates to the nucleus of the cell. And here it's involved in halting the cell cycle and causes transcription of genes that are involved in apoptosis or DNA repair. MDM2 is the protein that controls TP53, so it targets TP53 for degradation, keeping it in check. Variants in TP53 are loss of function variants, and the loss of function occurs in this DNA binding domain where it's no longer able to bind to the nucleus of cells. So prognostically, we can see in our latest ICC that a specific category is now allocated to AML with mutated TP53. And that can be mono or biallelic and carries with it a poor prognosis. What's interesting to note and expected is that when we have a multi-hit TP53, it behaves like a TP53 with a complex karyotype. So an even poorer prognosis in these patients. In the WHO, there is no specific category for TP53, and this was kept due to the frequent complex karyotypes present in TP53 mutated AML, which would then have allowed it to be classified as AML-MR. And secondly, due to this defining group, acute erythroid leukemia, which is noted to have biallelic TP53. Therapeutically, we know that there are P53 reactivators like eprenetipopt, which can be used in combination with azacitidine in our AML with mutated TP53. I find there's quite a lot of confusion around the concept of chromatin and what chromatin means. So I'm going to take you through the very basics. So what we mean by chromatin, we are referring to the DNA, which is negatively charged, and that negative charge is conferred by the phosphate groups, and that wraps around our histone proteins, which are positively charged, with that positive charge being provided by these lysine residues. When we talk about chromatin modification, so talking about that entire complex, there are three main pathways that we see. The first being DNA methylation, the other two involving our histones, either histone acetylation or histone methylation. So let's have a look at all those three. We refer to DNA methylation in the promoter regions of genes, and that is due to the very high cytosine contents in these CpG islands. When we methylate a gene's promoter, we cause silencing of that gene, so we do not transcribe that gene. So if we look at a methyl transferase like DNMT3A, we can see its function is in methylation of the cytosines, and that translates into repression of the genes. In AML, around a quarter of cases have a DNMT3A mutation. These are loss of function mutations. So in essence, we are losing the repressive function of DNMT3A. When talking about histone acetylation and methylation, we are talking about the tightness of the coil of the DNA around the histone, whether it is uncoiled or tight. So when we have uncoiled DNA that allows for the transcription machinery to enter in and allows for transcription of the genes. So when we acetylate our lysine residues, we're adding an acetyl group, and that leads to an opening up of the chromatin and allows for transcriptional activation. Histone methylation is slightly more nuanced, and it depends on the number of methyl groups that are added, as well as the actual lysine residue that is methylated. So we can expect to see transcriptional activation when we add a single methyl group to our lysine residues. whereas we see transcriptional repression when we add 2 to 3 methyl groups, or in the setting of methylation of this very well-known residue, H3K9K27, which we see at the top as well here. So if we look at an example of chromatin modification being affected, here we have the ASXL1 protein. And the ASXL1 protein interacts with BAP1, and together they move to our polycomb repressor complex. And the end result is methylation of H3K27, which we know is going to cause transcriptional repression. Now in AML, ASXL1 variants occur in around 11% of cases. And these are truncating variants. So we've got this loss of function of ASXL1. And so we get the loss of methylation of H3K27. And so you get this activation of gene expression. And this may look very familiar to the KMT2A slide, where we've got increased HOX gene expression, progenitor expansion, and differentiation arrest. Lastly, in this train is the RNA splicing. So RNA splicing occurs due to this conglomerate of proteins that remove the non-coding regions of our introns, leaving us with an mRNA that can then be translated into protein. What's interesting is that our spliceosome variants are actually gain-of-function variants. And the reason they're gain of function is that you get very dysregulated splicing. So you end up with a very abnormal mRNA, and that mRNA has got early premature truncation codons or termination codons. So we get these very truncated proteins. So how does chromatin modification and RNA splicing genes, how do they translate into something prognostic? So in both our WHO and our ICC, we see that variants that interact with our polycomb repressor complexes, with our spliceosome and our cohesin complex, when they are pathogenic and present at a variant allele frequency of 10% or more, they are defining of the category of AML-MR. The last of the proteins I wanted to look at was nucleophosmin 1. And nucleophosmin 1 variants have a very high association with cytogenetically normal AML. Nucleophosmin 1 occurs in 2/3 of cytogenetically AML up to. Now, the NPN1 protein is a nucleolar located protein, and it comprises a conserved N-terminal region, a central acidic region, and then a very disorganized C-terminal, which contains this nucleolar localization signal. This is the characteristic NPN1 frame shift mutation that we see. So it's a loss of function variant where we lose this folding and of the C-terminal region, and we lose this nucleolar localization signal. And so what happens is our NPN1 is delocalized to the cytoplasm of the cell, and here it interacts with proteins which cause a block in differentiation, driving of cellular proliferation, and an impaired repair of our DNA. So prognostically, we know that mutated NPN1 can occur with FLT3 ITDs, and when present with a FLT3, they are bumped up into an intermediate risk category. So that is the backdrop of the molecular pathways, the main molecular pathways, not all of the genes and not all of the variants that we see, but the main pathways we see in AML. Before we move on to the NGS data that we have obtained, I'd like to just run through very shortly and very briefly the updates to the WHO and ICC that will pertain to the latter half of the talk. I thought it really important to highlight this statement that was made in the WHO, and with specific reference to those very challenging cases pathologically. And in those situations, it's imperative that there's this integration of clinico-pathological judgment, and that we do not rest on any one method or any one clinical finding. So the emphasis in the two current classifications we now have are defining genetic abnormalities, and no longer are NOS, but AML defined by differentiation. MRD monitoring has become really important, and initial risk stratification may change based on this MRD monitoring, and that's very important to note. The variants that we see also dictate management and whether targeted therapies may be applicable in those cases. Because of the very arbitrary nature of cutoffs in terms of blast percentages, they have eliminated the 20% blast cutoff for AML with defining genetic abnormalities, with two exceptions. The first being BCR-ABL fusions, in order to maintain the distinction between CML and AML. And the second being AML with SEPA mutations, to prevent the inclusion of SEPA variants that have a low VAF and are unlikely to transform into AML. If we look at our AML with SEPA, we can see that we have now included these single mutations in the BZIP region, which are classically in-frame mutations. And these are associated or noted in very young patients, again with a high white cell count proliferative picture, and often on flow, we see a very bright CD34 expression. The new WHO has also created a category that allows for these new and uncommon AML subtypes. So RUNX1 mutations. This is really where one of the discrepancies are noted in the ICC, this and the WHO. So in our ICC, they fall under AML-MR. However, in the WHO, they did not feel that RUNX1 variants had sufficient specificity in order to stand alone as a criteria for a specific AML. AML-MR, so alluded to it earlier, we've removed morphology alone, and there are a set of 8 genes, which I showed on a previous slide, that require a VAF of more than 10%. Acute erythroid leukemia. So WHO wanted to keep it as a separate category, really to emphasize the extremely poor prognosis in this category, and this due to or driven by the biallelic TP53 alterations, and this entity supersedes AML-MR. TP53, we saw that this has got a specific category in our ICC, and for ICC, the acute erythroblastic leukemias would fall under here. Okay, so on that backdrop, I'm now going to take you through our public sector data, which I'm very excited to share with you. So we performed a retrospective study at the somatic cell units at Charlotte Maxeke, and we took that NGS data, as well as all the morphological and histological findings and the laboratory findings in terms of genetics and flow cytometry, in order to stratify and classify these patients. And we looked at all ages from pediatric to adults. Just in terms of numbers, we had a total of 194 AML cases. 21 of these we could not classify, and that was due to an absence of either good morphological or histological samples or genetic studies. A further 12 samples were removed because these were from a transform from an underlying MPN or from an underlying aplastic. The first interesting finding that we saw was a significantly lower median age than the 65 to 70 years that's reported internationally. And this even translated into the category we would expect to have the highest age, being our AML-MR, where we saw a median of around 50. Just to note, KMT2As, as expected, were enriched in our pediatric and young adolescent population. If we broke our AML down according to the WHO subgroups, the next two slides, we got a very good picture of what we had. But just to treat these results with an element of caution, the reason being that not all cases of AML are sent for NGS, and that may be due to patients being elderly and for palliative therapy, and so the cost of NGS could not be justified in those individuals. Or it could be due to the different treatment workup practices of different units. For instance, with APL, some centers would do FISH with FLT3 ITD PCR and not NGS. And thirdly, in some centers, the referral centers are quite far from the academic centers, and there's a very high mortality in those patients in that pre-referral stage, and so those patients would be lost from the follow-up. What was nice to see was that we were able to pick up some of the rarer variants with a panel. And a very large proportion of our samples, a quarter, qualified for the AML-MR category. What was quite frightening was that around 40% of these cases would not have been classified as AML-MR, as a high-risk category, without NGS. The second important finding was that in our cytogenetically normal AMLs, if we excluded cases of NPN1, which we know are associated with a cytogenetically normal AML, 19% of those cases would have been misclassified as cytogenetically normal versus being in another category based on the variant present. If we broke up our proportion of AMLs according to age categories, we saw some expected findings. AML-MR increased with increasing age, as did AML with NPN1, and our 821s reduced with increasing age. So to talk to the one major discrepancy between our two risk classification systems, it's that of AML with mutated TP53. According to the ICC, if we looked at our cases, we had 21 cases that fulfilled this criteria. 15 of those would have been mopped up in a high-risk AML-MR category with the WHO, but a third of cases would have been missed, either being unclassifiable or defined by differentiation. Moving on to the DNA variants that we saw a very high number of variants within two categories, that of AML with mutated NPN1, and that was excluding the NPN1 in that calculation, and AML-MR. So it sat at around 2.3 to 2.4 variants per case. On the other end of the spectrum was our APL, where we had a very low number, 0.5 variants per case. Looking at our core binding factor leukemias and our KMT2 rearranged AML, we saw a DNA variant in around 2/3 of cases. And that speaks to our earlier slide, where we said that cooperating variants are needed in order to drive that leukemia to overt leukemia. And it was classically in pathways that were signaling pathways, so our KITs, our FLTs, our N and K RASs, and they sat at a VAF, or variant allele frequency, of around 20%. We saw a very well-known association, which is 821 with KIT mutations. And this was in our classic exon 17, so 90% of cases had a D816 in those that had a KIT variant. The other variants that we saw in 821 were FLT3 ITDs and RASes. In APL, we exclusively saw FLT3 ITDs in 40% of cases, which really supported the practice of certain centers only doing PCR and FISH for workup of APL. If we looked at AML with MPN1, every single case had an additional variant, and these were in signaling pathways, epigenetic or spliceosome pathways. As I've stated previously, all of these cases were cytogenetically normal. What was an interesting finding was that around a quarter of cases were triple mutated. So that referred to the presence of MPN1, FLT3 ITD, and DNMT3A. And these are known to carry a very poor prognosis. Looking to the last of the genes that I wanted to look at, it was that of the SEPA gene. And again, we saw a very well-known association of biallelic SEPA with GATA2 mutations. And that carries a favorable prognosis, which is particularly pronounced in cases that have a zinc finger 1 mutation versus a zinc finger 2 GATA2 mutation. So based on the results of what we found, I wanted to transpose that onto a previous study we performed in Johannesburg that was done pre-NGS, just to see if we could try and explain some of the findings we had based on the NGS results that we have shown here. So what we found was that we had a higher rate of relapse in our 821s, sat at around 20%, and in our APL patients, which sat around 10%. And based on what I've shown previously, this is likely to be driven by the presence of KIT and FLT3 variants in our 821s and by FLT ITDs in our APLs. In a setting where there was a lack of therapies such as midostaurin and arsenic trioxide. And certainly if we relate it to our ELN, treatment practices may differ between different centers overseas and where we are. Another interesting finding was that we had a very early death rate, high early death rate of AML with NPN1. So a quarter of cases of patients demised within the first week. And these cases had a very high white cell count. And what we know from the literature is that cases that are triple mutated, so those with MPN1 and DNMT3 and FLT3, have a high white cell count, have a very high disease burden, a high blast percentage, and are known to have an adverse prognosis. And so our NGS results really give us a good picture of what was driving these poorer outcomes in our patients. The last thing I just wanted to emphasize was risk stratification. And we can see that really this big piece of the pie that is AML-MR is the big driver in the poor prognosis in our adult patients, whereas in children we can see an almost equivalent number of favorable and intermediate risk categories. So to give a good summary of what we found was that compared with international studies, we could see that our pattern of DNA variants was very similar to that seen internationally in terms of what we saw in the different subcategories and in terms of the different variant allele frequencies. But what was very pronounced was our much younger median age in our population. And that may represent an early exposure to toxins viruses, triggers of what may be driving AML nationally, internationally, all over the world. The poorer outcomes that we've previously noted in A21, APL, and AML with MPN1 are likely to be driven by these co-mutations with FLT-ITD kits and triple mutations, and a lack of uniform and easily available midostaurin and arsenic trioxide. And particularly within our A21s and our APLs, MRD follow-up is critical to pick up early evidence of relapse. In terms of our AML-MR, a quarter of cases fulfilled the criteria for this category. And really to emphasize that without NGS, 40% of cases would not have been classified as high risk. In terms of our ICC, AML with TP53, when we apply the WHO, 20% of cases would not have met the high-risk category, a high-risk category, because many lacked cytogenetics. And so in my opinion, it is of great value and importance in these cases to provide both labels when providing the final diagnosis. In terms of AML-MR and RUNX1, in our setting, it really carried a negligible impact. And so even though there are discrepancies between the ICC and WHO, it did not translate into discrepancies in cases with RUNX1. So in conclusion, again, I think that I have shown the point that I emphasize, that AML is extremely heterogeneous in terms of genetics. And what I want to drive home is that we really do require a multi-pronged genetic approach for accurate risk stratification. And I thank you for your attention and happy to open the floor for discussion.
Thank you, Kate. That was a wonderful overview and very insightful. I'm going to abuse my position as chair to ask the first question before I get to the chat box. In our center, we mainly follow up our AMLs with MRD flow. I mainly do the flow here. So I was just wondering, how sensitive is your NGS panel for MRD monitoring, and what is the value of doing that?
Thank you very much, Annika. So the current myeloid panel that we have only has a sensitivity of 5%. So it is not being designed for MRD follow-up. And as you say, according to the current guidelines, multi-parametric flow cytometry, if you're counting at least half a million cells, or a molecular technique that has a sensitivity of at least 10 to the -3 is needed for MRD. And so in cases where you have a nice driver variant fusion that can be picked up by RQ-PCR, that certainly is the route that one needs to go. I think also the challenge with MRD on NGS is what to do with certain of the variants. We know that NPN1 that persists at low levels post-consolidation doesn't necessarily infer a high risk of relapse. Also, if we're looking at our subclonal events like FLTs, N and KRASs, although those are markers of MRD, they have a very low negative predictive value if you're not using it in conjunction with other markers. And so if I could really emphasize that if you've got MRD flow or RQ-PCR, those are really the two methods currently that we have available in NGS in an NHLS that I would recommend for MRD follow-up.
Thank you. And then just one last question. Do you routinely do myeloid NGS on all your newly diagnosed AMLs at your center?
So at our center, we do, if they're not for palliation. But I do feel that for APLs, we should probably move towards FISH with PCR, because you will have done FISH as an emergency. And so in terms of cost, to reduce the cost nationally and save those cases for specific patients, I wouldn't do it in that setting. Yeah.
Okay, thank you. I'm going to go to the chat box. I see Dr. Jacques Malherbe was busy. So he made a comment. He said, I wonder if the intermediate risk category is applicable to our setting where FLT3 inhibitors are not generally available.
I totally agree with your comments and don't feel that it is applicable if we don't have the targeted therapy available from what we're seeing.
And then his next comment, it's also from Jacques. I'm interested in the comment that ATO overcomes the prognostic significance of FLT3 mutation. Is this only in the setting of APL or in other AMLs as well? I see there are studies looking at the effect of ATO on AML cell lines with FLT3 in general, but haven't found any patient trials looking at ATO users in AML other than APL.
Thanks, Jacques, very much for the question. As far as I'm aware, it is only in the setting of APL. I'm not aware of it being in any other setting of just an AML with a FLT, if that answers your question.
And then the last question from Jacques, the last comment is, it's really just a comment of an interesting case that he had. We have a patient who presented with MPN1 mutated AML. After therapy for this, she was MPN PCR negative, but bone marrow was suggestive of CML in chronic phase. And then she had a confirmed BCR-ABL positive. She was started on imatinib and she's doing well. MPN1 remains negative. Unfortunately, we don't know what the BCR-ABL was before or at diagnosis. And we also don't have a karyotype from diagnosis. So it seems like an interesting double.
Wow. I mean, I know that AML with MPN1s can relapse with MPN1 negativity, but I have never heard of this specific situation where we then have a different malignancy. That's absolutely fascinating.
Okay, and then there's a hand that's up. Zina, please proceed.
Hi, everybody. It's Zina from Durban. So, Jacques, I was just thinking that since we have the midostaurin for the FLT3 in AML, that is proven quite effective in reducing the allelic burden. And the second thing is considering that if you had an AML with a FLT3 who wasn't responding to arsenic, could you then use the midostaurin in the APL with the FLT3? But I think that's something we have to really research about. What I wanted to actually ask is, how are these molecular mutations guiding therapy? Because recently had a young male, about 25, with a NUP mutation. And as you can see that in your study also, there was just one patient in there. We know that if patients have AML with NPM1, they can have a year of aza-ven, and if their NPM1 is negative after a year, they could actually stop treatment. But do we have any evidence guiding how we will use these molecular mutations with regard to treatment? That's the one thing. And the second thing I wanted to ask is, we're seeing a lot of cytopenias in patients where the NGS is coming back with these mutations and possibly myelodysplasia. So I know this is AML, but looking at the myelodysplasia related cases where they're coming back with these high-risk mutations as well, how is that affecting treatment? If there's anybody out there who can answer that. Thank you.
Thanks, Inat. Just a comment from my side on FLT3. Trying to think of your question was, can you use FLT3 inhibitors in APL? I couldn't find it in any of the guidelines, any of the recommendations, because I had a case recently, whether it is recommended or not. I looked on UpToDate everywhere. I just couldn't find any solid evidence on what you're supposed to do in those situations if you don't have arsenic or if you've moved on from arsenic after on those patients.
Okay, I can just see Job commented. He says, I think midostaurin availability in South Africa is only for those with a lot of resources. Anyone else? Oh, please, sorry, Jock, yes, go ahead.
Yeah, I thought I'll just comment on the FLT3 in APL. I don't know what the experience in other centers are. I mean, generally, if our patients with APL go through the first few weeks and survive that without catastrophic bleeding, we see very, very few relapses, and we don't have access to APL, to ATO, and we treat with the there's a Spanish protocol. I've forgotten the protocol number now, with Atra and daunorubicin mitoxantrone based therapy with cytarabine for the high risk patients, we looked at our outcomes. I think if we include early deaths from hemorrhagic complications, I think about 70 to 75% of our patients get through therapy, and we just had an APL relapse, the first one in I think 7 or 8 years that has relapsed. And so I'm not sure, if you because you found a reason, what was your percentage of FLT3 in APL?
We have around, this was nationally, Jacques, was 40%.
Because I mean, so I'm not sure how significant the FLT3 in terms of prognosis in APL is. I know there's a bit of contention in the literature, but I don't think the impact in APL is that significant. And I do think ATRA-based chemotherapy does overcome that to some degree, because we seem to be getting, at least, in our center, very good outcomes with our APL. So those that don't, as I said, don't die early from complications. So
Jacques, do you know offhand how many of your patients have FLT3s?
No, not offhand.
Okay.
I don't know if Anneke has that information. Yeah.
Okay,
I'm
interesting. Very
supposed to
interesting.
have it, but I can't also remember offhand. I'll have to check.
It would be interesting to see. And just maybe, Zeenat, I'm not sure in terms of the in APL and FLT3. Yeah, I don't know if the FLT3 inhibitors like midostaurin and the others have been used, but I think, I mean, if you've got access to ATO, I don't think there will be many that would require that.
Fair point.
So.
Okay.
Okay, Zeenat, your hand is still up. Is it from the previous question, or do you have another question?
No, that's from the previous question.
Okay.
Thank you.
So anyone else, anyone wants to ask, you're welcome to just unmute yourself and ask.
Hi, can you hear me?
Yes, please go
Hi,
ahead.
this is Adam Bagg calling all the way from Philadelphia. I just wanted to congratulate Catherine on a great talk, very comprehensive, very coherent. I had one or two comments and questions, if there's time for that. And that is, one of the questions I had, what is the turnaround time for your assay?
So not great, Adam, but thank you very much for your question. We target around 3 weeks, but with current crises that we've had with crashing systems, it has not been ideal, but that's what we try and aim for.
I think, that's obviously a universal issue with NGS assays in most institutions, including our own, in which we're very excited if it'll come out in 2 weeks, but it's often closer to 3 to 4 weeks. I would encourage you, your data on the young age of your AMLs in general and the young age of those with myelodysplasia related abnormalities is fascinating, and I would encourage you to put together a report on those. I think that would be something that would be well received, and also obviously an area of additional investigation regarding, as you mentioned, whether there's something environmental, accounting not only for the young age of even the good prognosis A21s, but as more intriguing perhaps are the NDS related mutations. So I think you should really consider putting those data together and writing that up. I think that's all. Thank you very much.
Thank you so much for that. I really appreciate it.
Okay, then you may have 2 hands up. I think Jacques' hand was first. So Jacques, please go ahead.
No, I've forgotten my question. Let Estelle go first.
Estelle, please go ahead.
Hi, Catherine and Anneke. Beautiful, great work. I think your article is still in press, Catherine. or not?
Correct. Yes.
Okay, because I had a little sneak peek, courtesy of someone, but my phone was stolen, so now I don't have it anymore. You know, it wiped everything. You know what happened? It sort of wipes everything on your WhatsApp. So I just want to respond to Prof. Bag's input. I mean, it looked very impressive, the young age, but I guess that the patients in the study come from across the country.
Correct.
Okay, so I mean, I think that answers this conundrum, because we do not have money to send. We do not send it through for patients over. Well, I hate to actually give the age. That's a topic for a different day. But we know that we cannot treat patients intensively in our system. I mean, even 65 is too high. So we would not be sending in NGS. On the other hand, to support his interest in this, we do have less older leukemias. So yes, we select them out. We do not send NGS for older people. That's true. And we don't send it for people we don't treat. I don't think it's an exact science. Sometimes it may slip through for a younger person or an older person that is still 65, and we know we're not going to treat. We typically go for winners in the South African situation. We do try to treat people that have either the more low-risk AMLs, obviously starting with a very low, the lowest risk APL and upwards. That's what we treat. We do not go for very complex AMLs in 60-year-olds. And we find that our patients' biological age is absolutely an impediment to intensive treatment. And I think you know that from your contact at WITS with clinical, the clinical world. We really have a huge problem in treating them. So I think there's two reasons for your low age. It's selection. But I think the fascinating question of, are people just dying younger in South Africa? Are they not getting old and getting AML? You know, is it a genetic reason why we don't have older, less old AMLs? I can't answer it, but I think it is fascinating. And yeah, good luck on you and those who do AML research to find out for us. Don't know if you've got a comment on that.
Thanks so much, Estelle. I actually do. Thank you very much for your thoughts into thinking why the age was much lower. What we actually found and what was interesting, and I do think it might be differ by the different provinces across the country, but in the previous paper we did, the pre-NGS paper, those patients, we did flow cytometry. That's how we found the patients and enrolled them. So there was no exclusion based on age. In that paper, we had the same lower median age. So I know in Johannesburg specifically, we have a lower median age. I can't speak to the rest of the country, but my feeling is that Western Cape, we are seeing a slightly older population. But certainly in Johannesburg, we are seeing that lower median age. And we are seeing it not just with AML, but certainly with our other hematolymphoid malignancies as well.
The interesting thing would be to know if it's different in private practice. So is it a function of poor socioeconomics, or is it, I don't want to, but there's many different questions.
Yeah.
Also genetic differences, ethnic differences.
So definitely, and also whether elderly patients in the public sector actually seek treatment. They may be dying at home. So there could be many factors that are contributing.
Thanks, Catherine.
Thanks so much.
Jacques, did you remember your question?
Yes, and I've got another comment. So, yeah, just regarding maybe, I mean, Anneke will know, but we also don't send routinely samples for NGS, but we have sort of made the call that we often would say that let's store DNA in case one will need it later. on for a case where it may impact treatment decisions, should we think about transplant and things like that. So I think that may be something that one could look at, to have that ability to have a diagnosis sample, and if you later on feel the NGS may impact your treatment pathway, it may be worthwhile to do it then.
Yeah, I think that's
maybe
an
in a-
excellent suggestion, Jacques.
Yeah, so we do that, in our center. Then just regarding the younger age, I think there may be, I mean, and also just to echo what Estelle has said, that I do think there's possibly also a bit of a referral bias contributing to your younger AML age, because we would often not do extensive investigations on a patient over, I mean, we do occasionally treat older AMLs over the age of 60 if they're really in a good condition, and we would treat them intensively, but that's few and far between. But often if it's an older patient that we feel is for palliation, we don't do extensive investigations because we don't, I mean, we don't have access to targeted therapy or azacitidine even, or we're definitely not venetoclax. So I think, that I think probably contributes to maybe skewing that distribution. It's but it may be worthwhile to look at it in a population where you capture most patients. So,
Thanks, Jacques.
Okay, well, I don't know if anyone else wants to ask another question. I don't see any hands, and there's nothing left in the chat box. So I think what's left for me is just to say thank you, Kate. This was a wonderful talk. I'm very glad that this session is recorded so that we can go back. I think it's for the registrars also very important to just revise the physiology, or sort of the pathophysiology of these mutations. But thank you very much, and thank you to everyone who attended, and drive home safely.
Thanks so much, Annika. Bye, everyone.
Thank you. Thank you.
Thank you.
Bye.